and thank you for the invitation just to speak. So hopefully my slides are up. So just going to talk a little bit initially about lung physiology and airways disease, just to kind of put a little bit of context around what the impact of air quality may well be. And then towards the end, just to look over some of the data, including a bit we've done locally about what irritates the lung and therefore what will irritate a respiratory physician, because obviously we'd like to try and keep our patients out of hospital and as well as possible. So I always, when I'm talking about something, I always like to try and, what we're talking about, what are the lungs for, which sounds like a slightly obvious question in many ways, but it's useful just to think about that, because actually the kind of function of the lungs actually also then results in some of the diseases that we see and the impact that the air quality may have. So primarily the lung is for gas exchange, so it takes in oxygen from the air, which is used in the kind of metabolic processes of the body, and then eliminates carbon dioxide to get out. And that's the kind of quite simplistic what we see happening kind of day to day. But actually, the lungs are also incredibly important for maintaining a lot of the kind of homeostatic processes within the body. So the pH of the blood is maintained in this very tight range between 7.35 and 7.45. And the lungs are incredibly important in maintaining that balance. And it's a kind of, from a respiratory point of view, is if we see acidemia or acid within the blood, that's a very worrying sign, because it's a reflection that the lungs have decompensated and you're into trouble. So that's hugely important. And if your pH is out of range, then you start to run into problems with the metabolic processes, proteins start to denature, and all sorts of other consequences. So it's hugely important for the whole of the body. And then there's also a major issue in terms of protection from infection and preventing infection. The lungs have got all sorts of defense systems that will get organisms out of the lungs if we inhale them. And you may or may not be aware, but the kind of commonest cause of death in the UK is probably pneumonia as the kind of terminal event, which is a lung infection. This kind of garners a lot of focus in terms of why are people dying of pneumonia, but it's quite often just a reflection that actually that people are advancing, and this is just a terminal event as other health issues take over. So that's kind of what the lungs are for. And the other thing is to think about is how much air do we breathe, and with lots of kind of lung physiology, we talk about lots of volumes and bits and pieces, but it's actually quite a phenomenal amount of air that's going in and out of you each day. So we talk about what we call tidal volume, which is the volume of air you move in one inspiration and expiration cycle. So if you breathe in and you breathe out, your tidal volume is how much air you've moved during that period, which is, roughly speaking, about 5 seconds is your kind of your tidal time. So each cycle is about 500 mils, which is kind of half a pint, a bottle of Coke. You take 12 breaths a minute, so you're moving around 3 liters a minute of air, which is about 180 liters of air an hour, just under 5,000 liters a day. And over a year, that's about 1.5 million liters of air that the lungs move. So phenomenally huge amounts of air are going in and out of your lungs. And that then obviously gives us opportunity to quite significant exposures to all sorts of things. And this is just kind of the structure of the lungs. So there's various bits of the lungs that we need to think about and to consider. So the main bit is the main bit of plumbing is the trachea, so the kind of main windpipe running through the center of the chest. This divides off into the bronchi, which are the main conducting airways into each lung, and these then gradually divide off into smaller and smaller airways as you get towards the periphery of lung, a little bit like a kind of an upside down tree or a root system. These airways have got all sorts of defense mechanisms to try and get secretions out, and there's all sorts of kind of sensors that will detect noxious things that come in. And quite often one of the things, the commonest symptoms we see for patients with respiratory symptoms is a cough, and that is a defense mechanism. If you inhale something, your immediate response is to cough to clear it out of the airways. As you then go down into the smaller and smaller airways, you get into what we call the alveolar structures, which are very thin membranes, single cell membranes that are where the gas exchange actually occurs. And this is the gas exchange surface, where it's a very efficient gas exchange process. This is a phenomenal surface area of about 50 to 75 meters squared. So the kind of ballpark figure is that is about half of a tennis court. Is kind of, if you kind of got all your alveolar structures and flattened them, it would cover about half a tennis court. And then alongside all this, there's kind of scaffolding that hold this all in place. And this is what we call the interstitial tissues. I'm an airways doctor, so I'm primarily interested in the airways and airways disease. So I'm less interested in the interstitial structures, although I will touch on that a little bit later on. And some of my colleagues are much more interested in the scaffolding rather than the conducting airways. And we as respiratory physicians, we measure all sorts of things, and we kind of like to measure and kind of compare things. And you may see studies of what are we measuring, and so these numbers you may see bandied about. So FEV1 and FVC. So FEV1 is the amount of air you can exhale in 1 second. So you do a maximum inhalation, blow out as hard and as fast as you can do, and you measure how much air you've blown out in 1 second. And then the FVC is how much air you can then completely exhale from maximal expiration. So that's the forced vital capacity. There's lots of other measurements that I won't go into because these are probably the key ones, and these are the ones that we use on day-to-day practice. Now, the reason these are important is that we use a ratio between the FEV1 and the FVC to decide what kind of lung disease someone may have. So if the ratio is above 70%, then we define this as a restrictive defect, or it may be normal. And so this is as a cause of breathlessness. I describe this as, if you can imagine trying to blow up a balloon in a small box, is that there's something restricting the balloon inflating further. So that's the maximum volume. So that's what we call a restrictive defect. And then if the ratio is below 70%, we describe that as airflow obstruction. And that's like if you're trying to blow up a balloon with a small straw. So if you want to kind of test this, how a patient feels getting breathless, you can try and exercise with a straw in your mouth, and you'll find it much harder than if you just breathe through your mouth normally. And that's because you've got a much narrower tube, and it's much harder to inspire and expire. You can do the same with a restrictive defect, but it involves having to try and put a straitjacket on to restrict your chest wall movements. And so I don't necessarily recommend that. And the reason this is important is we then start to divide up lung diseases into airways diseases, which tend to have a airflow obstruction, and we tend to then other diseases. So the restrictive lung diseases are where we've got a different lung function pattern. And this is important for us because the treatments for these diseases will vary depending on what type of airways disease or restrictive disease you have. And quite often, from a symptoms point of view, patients just they may describe breathlessness, they may describe a cough, and they may describe some tightness in the chest or wheezing, but there's not much else to go and say, actually, this is going to be this kind of condition or this kind of condition, which is why their lung function is very important. So if we think about airways disease, we've got asthma and COPD are the two big common ones, and they've got varying patterns of airflow obstruction. So asthma tends to change from day to day and from time to time, whereas COPD is progressively worsening airflow obstruction. For the restrictive diseases, they can be, as I say, issues with scaffolding in terms of pulmonary fibrosis. The other thing that we can see is if you've got a chest wall issue. So as you breathe in and out, your diaphragm moves up and down, and your ribs move in and out, and that's what causes you to inspire and expire air. If you restrict the chest wall and don't allow your ribs to move, then that causes a kind of mechanical issue with breathing. The thing that we see most commonly now, in the modern world, causing a chest wall problem is probably obesity. And as you put more and more weight on, is the ability of your ribs to move in and out becomes restricted, and that's sometimes what can cause patients to become more breathless. So, as we move on to COPD, we're talking about kind of progressive airflow obstruction. There is an inflammation within the airways. And there's also what we call emphysema, which is loss of the alveolar tissues. And so you lose surface area for gas exchange. And this tends to be what then results in breathlessness. By far and away, the biggest risk factor for COPD developing is tobacco exposure. And that's why we are very anti-tobacco and big tobacco. And there's all sorts of things I have to sign as a respiratory physician if I want to join kind of various respiratory scientific bodies, is I have to say that I absolutely have nothing to do with the tobacco industry, and I don't have any conflicts of interest with them. But worldwide, there is other causes of COPD, and certainly if you look into the developing world, then cooking on open fires and biomass fuel exposure in the indoor environment can be important. And certainly if we see patients coming from the developing world into the UK, quite often they have evidence of COPD, and that's quite often related to biomass fuel exposure rather than tobacco exposure. And then there's this question about ambient air pollution that seems to be becoming more and more important, maybe not as a cause of COPD, but certainly as something that may well worsen it. And we'll touch a little bit on the data on that. And this is why we think tobacco exposure is so important. This is the Fletcher-Peto curve. So Fletcher and Peto were epidemiologists that really kind of nailed the first kind of epidemiological evidence that tobacco exposure was related to COPD. Prior to that, so this is relatively recently in terms of the late 70s. Prior to that, there was no kind of, it was always suspected that tobacco exposure was responsible, but they kind of really nailed it, and they actually studied doctors at the time with serial lung function, and they found that those who were healthy, non-smokers, didn't develop COPD, and then they had these cohorts who smoked for a number of years and then stopped at various ages. And what they found was those patients who smoked tobacco had accelerated lung decline and loss of lung function, which related to breathlessness, disability, and death as things progressed. And so this was the first kind of nailing it on. And I think tobacco exposure does offer us some kind of links with air pollution, as it's a very kind of defined way of giving yourself air pollution in some ways. And I do think it's a kind of an exemplar of what we may need to think about as we move into looking at air pollution, air quality in terms of its impact on airways disease. Tobacco exposure is quite nice in some ways because you can quantify it a little bit, and I think that's one of the big challenges that we have with air pollution, is that it's much harder to quantify. So we can quantify tobacco exposure, and we talk about what we call pack years to our patients. So if you smoke 20 cigarettes a day for 1 year, then you've accumulated a 1 pack year exposure, and you can then multiply that up. So if you smoke 20 cigarettes a day for 20 years, then you've got a 20 pack year history. And so we can start to quantify this and to measure it a little bit. And I think that's one of the things that we really struggle with air pollution exposures is how much have you been exposed to, because it does vary so much. Duration of tobacco exposure, however, does seem to be more important in terms of predicting lung function decline. This is a paper from a few years ago that really kind of demonstrated that quite nicely, as those patients who'd had a longer duration of tobacco exposure, so for less than 10 years, 10 to 20, 20 to 30, 30 to 40 years, or over 40 years, is that they're the patients who had worse lung function and more evidence of airflow obstruction. There was a little bit of a relationship between the number of cigarettes that has been smoking over that time, but it wasn't as strong as the duration. So duration certainly is much more important than the absolute quantity of cigarettes. And some of that is probably to do with recall biases, that patients don't necessarily are not necessarily absolutely accurate in knowing how many cigarettes they smoke most days, and sometimes will underestimate how much they've smoked historically. So whereas they know when they started smoking, they tend to know when they stopped smoking. So the duration is much easier to calculate. And air pollution has been increasingly recognized as a risk for respiratory mortality. The impact on lung function is less well established. And I think that's some of that is to do with trying to quantify exposure and then relating to that to changes in lung function measures. And I think that's a real big challenge. This study from the UK Biobank has looked at just over 300,000 individuals, and this was quite a nice cross-sectional analysis of land use estimates for various air pollutants, including PM2.5, 10, coarse and nitrous oxide. And they looked at lung function measures in a cross-sectional basis, demographics, and a diagnosis of COPD. And they did find there was a relationship, particularly with PM2.5, but also with PM10 and with NO2, with increasing exposures. There did seem to be an increased risk of developing COPD. There's a lot of kind of noise within this study as well, though, because there's other associations which may well be confounding. So they found stronger associations with men than women, which is actually slightly unusual because you tend to find that women are at more risk of lung disease than men in general. But actually in this, the association was stronger with air pollution, and that may have something to do with other issues that may be socioeconomic in terms of job and employment. Lower income households, I think, is something that we see repeatedly in studies, as those patients with evidence of socioeconomic deprivation are at higher risk of developing airways disease. And there's certain at-risk occupations, and we historically have recognized things like coal mining as a particular risk for developing COPD in the absence of tobacco exposure. The diagnosis of COPD was, again, associated with obesity and not being asthmatic. So again, this may start to tease out patients who may be at risk from developing lung function problems related to air pollution. And this is again another study looking at exacerbations, and exacerbations of COPD is a sudden worsening of those symptoms. And this is a big issue for us as a health service and as a health system, because unplanned utilization, so an exacerbation of COPD resulting in you going for an emergency visit to GP or an emergency visit to the ED, is a big driver for costs within the health service. And that's something that we really want to try and get down at all possible. And this study again showed with increasing exposures to pollutants, there was small increases in risk of exacerbations. And that impact seems to be, this is a global study, that impact seemed to be greater in lower middle income countries, but the same was seen also in more developed countries. It's just worth noting that the odds ratios here are small incremental, although they're statistically significant, there are small incremental changes. So these aren't massive impacts, but they're having a small incremental change. And look at asthma, and this was slightly a kind of controversial area in that there's been an increasing prevalence of asthma since the 1950s, and there's been lots of kind of thoughts about why that was, whether it's to do with we live in now a cleaner environment generally, and whether there's kind of what we call the hygiene hypothesis, we're not being exposed to infections as much, and there was kind of an issue about awareness of diagnosis of asthma. That actually, is it just that we're more aware of people with asthma now, and so we diagnose it more? So actually, is it just we're detecting it more? But there's always been a question about is it related to environmental exposures? And early studies looking at this really kind of dismissed air pollution as a cause of increasing asthma rates, and it was kind of very much put onto the back burner. But I think more recently that has started to become more evident, and the kind of certainly the coroner's case that Stephen Holgate was involved in, I think has really raised that this is actually probably a bigger issue. So there are more studies now suggesting that there is an association between air pollution and asthma, and there's some evidence that children may be particularly susceptible to the impact of air pollution. Early life, as you're growing, is particularly critical for organ development, and we see for a number of things is that as patients are, or as children are growing, their lung function increases over time as their chest gets better, the lungs develop. And we're aware of a number of children where something has happened that has stopped their lungs developing, and these patients never develop their full lung capacity. The reason that's important, it means that you then got less lung function to kind of live with as you progress through life. Children may also be have a kind of an intrinsic exposure to these things because they've got a higher ventilatory rate per weight. So if you look at how much a child breathes per kilogram of weight, it's much higher than that compared to an adult. And also, children tend to have more outdoor exposures compared to adults, in that they will have time when they're playing outside, whereas adults may not have as much outdoor exposure. So there's lots of things that may drive these things in children. So looking at this kind of the kind of risk of pollution in terms of developing asthma, this again a meta-analysis of 41 studies, again small incremental impact as you increase up the pollution, small percentage increase in terms of a relationship with developing asthma. The one that stands out is NOx as a much higher risk, and this really supports that traffic related pollution is associated with the risk of developing childhood asthma. And that is important because asthma can be a lifelong disease, and actually if we get pollution controlled, we may then reduce down the incidence of childhood asthma, and we then prevent people from developing asthma, which is a long-term respiratory condition requiring treatment on a daily basis. There are issues with this meta-analysis, and it is difficult, but that I think is one of the challenges of a lot of these studies where you're looking at relating air pollution to diseases. Is there was a reliance on doctor diagnosis, and one of my things, in fact, later on this afternoon, I'll be doing my asthma clinic, is there's a huge amount of under and over diagnosis of asthma within the population. The reasons for that are slightly complicated. It probably isn't a massive issue in that the underdiagnosis probably compensates for the overdiagnosis. But again, when you're wanting to really kind of pin these things down, it is nice to be absolutely sure that you've got a diagnosis of asthma. One of the big challenges, I think, when you look at these epidemiological studies is assessing exposure risk. And a lot of these studies use different models to say this is how much exposure this person may have gained. And I think it's really hard then to compare between these studies because they use different measures and different assessments. And there is a potential for co-founding factors. Socioeconomic status, we know, is a risk factor for developing asthma as well as for COPD. And is that a chicken and egg? Is it because if you live in a worse socioeconomic area, you're more likely to have a higher exposure to air pollution, or is there something else that's driving this? Again, this links into tobacco smoke exposure, which is an independent risk factor developing asthma. Again, is there some interaction going on there? And there are also genetic factors that predispose people to developing asthma. So again, how do we tease that out, and how do we start to work out who may be vulnerable to the effects of inhaled poor air quality? And obesity does seem to be, again, interacting with air pollution. And again, obesity is an independent risk factor developing asthma. Obesity does all sorts of things to people. It seems to trigger off an inflammatory, systemic inflammatory response. There is evidence of increased oxidative stress within patients who are overweight. And so there's a question about whether this primes the airways for then an inflammatory response. So you've got someone who's overweight, who's got a kind of a baseline inflammatory response. You then put in a trigger of air pollution, and that then triggers off more inflammation, more damage, and therefore resulting in a higher risk of developing disease. But there's also a question about whether obesity results in increased exposure to air pollutants. And this has been just kind of nicely looked at in this study from this year from the ERJ, looking at children with a higher body mass index. And what they found for these children with a higher body mass index, and so they were overweight, is that they had an increased tidal volume. It wasn't a massive increase, so about 25 mil increase, so not huge amounts, but as you saw right at the beginning, is a small increase in your tidal volume, actually because it's happening so often and so quickly, is actually results in a significant increase in the amount of air that person is being exposed to, because it multiplies up because we breathe all the time. And they went on to do some other quite nice work looking at how much of the PM 2.5 was being retained by these patients. And they found that these patients were retaining about just over 3% more PM 2.5s within the lungs than those patients who weren't overweight. So you're finding potentially an increased exposure, but also increased retention of these particles within the lungs. And therefore, the question is whether this results in a higher inflammatory response within the lungs, and then moving on to develop potential airways disease. This is some local data that we looked at in Leeds that we did with James Tate about 4 years ago now, just before the kind of pandemic hit, where we looked at nitrous oxide and NO2 levels and related that to the daily number of asthma admissions into both the LGI and the St James's hospitals. And again, we found as there's increasing levels of nitric oxide exposure, is that there was a relationship as an increasing number of asthma admissions on those days. And again, it just kind of gives that hint that this is a kind of a population effect across the whole city. And how do you then tease that out to the individual patient is really quite difficult. James and colleagues want to look at air pollution, asthma exacerbations, and this is again a meta-analysis of a lot more studies and a lot more bigger studies than our little local study. And they again found an association between major air pollutants with moderate and severe exacerbations of asthma. And moderate exacerbations of asthma generally are going in to see a general practice, whereas a severe exacerbation is usually into the emergency department, the A&E, or into admission into hospital. Again, kind of odds ratios for all these different pollutants in terms of NO2, PM 2.5, ozone. Again, small incremental changes, but again, across a whole city, and may well be having a significant impact in terms of pushing patients at a higher risk into hospital or into the emergency department. Interestingly, this meta-analysis didn't find association with sulfur dioxide or PM10, although there was a numerical increase that wasn't statistically significant as the odds ratio crossed 1. So the kind of story in terms of air pollution and asthma exacerbations, the majority of these studies were in developed countries, and there's very little data from the developing world. And that's again is a question I think that probably needs to be answered in the longer term. And again, as with the other studies, the kind of the meta-analyses, is there's a wide range of methodologies to look at assessing the exposure risk for the population, and as there's going to be pros and cons with all those methodologies, and it's whether we need to move towards some kind of standardized, kind of almost what we need is the pack year history for air pollution. There are other rare airways diseases, and this is bronchiectasis, which is one of my other interests. So this is a very heterogeneous condition, and one of the reasons I like it is it's there's very little kind of evidence behind a lot of what we do. It's a bit more kind of medicine as an art rather than as a science. And these patients have airways dilation, so their airways are actually bigger than they should be, and this results in chronic airways infection. And so there's a wide range of causes, including problems with your immune system, so your ability to fight off infections, issues in terms of airway clearance, so things like primary ciliary dyskinesia, or one of my other interests is cystic fibrosis, plus many, many other causes. And this was a really nice study look from James Chalmers' group in Dundee, which is, I've got a slight affinity to, as this is why I did my undergraduate studies. And they looked at a case control study looking at just under 7,000 exacerbations, so kind of infective episodes requiring antibiotics, from their cohort of just over 430 patients. And they found actually a really quite strong signal in terms of increasing exposure with an increased risk of infection and resulting in a need for antibiotics. And so that they kind of found an 11% risk increasing, or just over 5% risk with the nitric oxide risk of exacerbations, which is a little bit higher than that we were finding with COPD and with asthma. Interestingly, find that there's a seasonal variation with their patients in terms of spring and summer, with a particularly higher risk. And there may be interactions there with particularly spring and summer in terms of other things that may well be happening in terms of viral exposures. And the other interesting factor that we didn't see, they didn't see, was the interaction between socioeconomic status and air pollution. Now, that's a trickier one to disentangle, because that certainly seems to be a much stronger signal that we saw in other airways disease, such as asthma and COPD. Now, I know Dundee quite well, having spent 6 years there, and it may well be something about Dundee, and there's quite a peculiar microclimate within Dundee, and it just makes you wonder. It's a coastal city, and there is a slightly weird environment on many levels, and it may be something particular about the setup of the city within Dundee that may have lost this interaction between socioeconomic status and pollution. The other thing that they did, and they looked at really quite nicely, is to looking at the lag between exposure and exacerbation. So is there something about, when you're exposed, is how many days afterwards were you most likely then be seeking healthcare intervention? And what they found was that the risk was actually highest on the day of exposure. So when the exposure was the highest, which is slightly contrary to what we found in Leeds when we were looking at the asthma cohort, is that those patients, that the risk was highest when it was about day 3. It was 3 days prior to hospital attendance was for the cohort with asthma. So again, it gives this kind of feel that different diseases may respond differently to different pollutants. Just moving on, I have to talk a little bit about the kind of rarer interstitial lung diseases. And this is a slightly more interesting story when we look at air pollution, because and these are a harder group to study in some ways. In the asthma and COPD are very common, whereas interstitial lung diseases are very rare, and this makes it harder to gain a cohort of patients where we can look at it. But there's a couple of studies just looking at annual pollutant levels with risk of developing IPF, or idiopathic pulmonary fibrosis. And they found that with increasing exposure to nitric oxide, or PM 2.5 or 10, was really quite a significant and much stronger signal than we maybe saw with other airways diseases. So these patients particularly do seem to be susceptible. So if you've got IPF and you've got high pollution levels, an exacerbation of IPF is really much higher risk. This is important for these patients because for these patients, an exacerbation of IPF has got a significant mortality associated with it. if you're admitted to a hospital with an exacerbation of IPF, you're looking at about 20 to 30% mortality. So actually, for these patients, if air pollution is really acting as a trigger for these episodes, that's really very important for these patients, and may well be something that we need to look at in terms of trying to reduce down what is a potentially life-threatening episode for patients. I think we have to be slightly cautious for that because the numbers we're looking at for these populations are quite small. When they look at the risk of developing these diseases, there does seem to be a little bit of data, a little bit of a hint that patients who have got exposures, and particularly to nitrous dioxide, may well be at higher risk of developing IPF, but it's a very kind of sketchy data. I don't think we want to hang our hats on that at all. So I think we have to be cautious about that. But there's just a signal there that these diseases where we really don't know why they occur may well be related to a degree of air pollution. So when we look at kind of summarizing all the different meta-analyses that have been looking at respiratory disease, in terms of developing a disease and having exacerbations of those disease, the thing that seems to be consistent is NO2 seems to be the marker of or related most strongly to developing and causing exacerbations of those diseases. But PM2.5 and PM10, the data is a little bit more variable. For some diseases, it may well be more important. For other diseases, it seems to be less important. So again, it just gives that hint that different diseases may respond differently to different triggers. I couldn't really not talk about kind of air quality and respiratory disease without mentioning the C word, or COVID. And there's some very interesting things that are now starting to come out in terms of what happened during the lockdowns. And it was a very interesting natural experiment that we undertook on a whole population, which well, hopefully will never be repeated again. And it was a very odd time on all sorts of levels. It was COVID. There was just one virus circulating at that time. So, you know, it's the last 2 years, I've just seen COVID as the only virus that we've had really circulating in the population. As a respiratory physician, I didn't see flu for 2 years, which is just really odd. It's been a very odd time. But there was also significant reduction in air pollution, and it's really interesting. I think there'll be a lot of interesting work done. I think looking at, was it the reduction in viruses, was it reduction in pollution? But certainly something happened that meant that we saw a lot less patients coming in with airways disease. This is data from Scotland and Wales, looking at when they implemented their lockdowns. So the dotted line here is when the pandemic was declared, and then the solid line is when the relevant Wales and Scotland lockdowns came in. So this is historical data of the blue triangles, and you can see that it's fairly kind of consistent pattern that we see over the years in terms of patients coming into hospital with exacerbations of COPD. Whereas in 2020, it just dropped off a perch and really didn't pick back up to the kind of baseline level, even back into July when the lockdown was fully released. And we see that both in Scotland and in to a lesser extent Wales, but the pattern was still the same. And we saw exactly the same pattern with asthma. Again, we see a very kind of carefully monitored pattern of asthma exacerbations as you go through the year. We tend to see spikes around January time and September time, quite often driven by viruses. But again, you can see the kind of 5-year average is very similar data. And then it just dropped off massively and really hasn't come back up in terms of asthma exacerbations at all. We're seeing a lot less patients coming into hospital with exacerbations of asthma now, even 2 years down the line following the lockdown. And whether that's related to changes in terms of commuting and less traffic on the roads, or whether it's related to viruses, is really hard to tell. But I think that there's some interesting questions that need answering. And this is global data looking at global PM2.5s So you can see over the 2019 and 2020, there was a drop in terms of PM 2.5 globally. So again, it had an impact. And what was that impact in terms of overall health? It's going to be something I think the epidemiologists will be looking over for a few years to come. I guess the question in some ways is why is all this important? Is these small changes in risk of exacerbations of asthma and risk of developing asthma and COPD, they do seem to have small impacts, but these smaller impacts I think will result in reduced healthcare costs if we can get air pollution down. And the reason for that is common things are common. So there's a lot of patients with asthma, there's a lot of patients with COPD in the UK. About 10% of the population probably has a diagnosis of asthma. So if we make a small change in the health of those patients, it actually has quite a significant impact in health costs. This is kind of wrapping up now. So this is looking at UK, the top 10 drugs for the UK spends on its drug bill. And this is in millions of pounds. So the highest drug was apixaban, which is just under £300 million. That's the total spend in the NHS in 2019. That's a relatively new drug and relatively quite expensive and used commonly. That's why the drug cost was quite high. So the top 10 drugs in the UK was just about £1,785 million for those. That's just the top 10 drugs. That's not the whole drug bill. Of those, 50% of those drugs were for a respiratory disease, which is about £708 million that we spent on very common drugs for people with respiratory diseases. To put that into context, the cystic fibrosis drugs, we've got some very expensive drugs, which are just for a very small number of people, for about 7,000 people in the UK. We're going to spend probably about £500 million over 5 years for those drugs. So this is a huge amount of money that we're spending. So if we make a small impact in that drug bill of £708 million, that is quite a saving in terms of drugs, let alone the lost income in terms of patients being off work. Huge amount of spend in terms of the GDP of the UK as a whole. So I think the challenges that the kind of for us as respiratory physicians, and what do we mean by poor air quality? Is it length of exposure? Is it quality of exposure? Is it short, high dose exposures? Is it long-term, low exposures? There's that interaction between indoor, outdoor travel, commuting, huge questions that we need to try and understand. I think we do need to understand the synergies that are going on between varying pollutions, obesity, different airways disease, viruses. These things interact, I think, in a very complex way, and I think we still don't quite understand those interactions fully. And so this is my last slide. So this is, for those of you of an age, this is Blur's album from the 90s, Modern Life is Rubbish. So we kind of almost, kind of in a perfect storm of air pollution, reduced physical activity, viruses knocking around, obesity, tobacco exposure. I've not even touched upon vaping and the e-cigarettes, because who knows about that? And all of these things are interacting to cause issues with our lung health. Thank you.
Thanks very much, Ian. That was fascinating. So have you got time to stick around for some questions?
Yes, absolutely. Yeah. I've got to, well, yeah.
So if people could put their questions in the chat. I don't see any at the moment in there, but I would like to start if this is nothing. So people can think of questions that they have for Ian. Quite a few things came to my mind, actually. Actually, the data that you showed comparing NOx and NO2 and showing a much higher risk than NOx was quite curious for me, actually, because we teach, and I always thought that NO2 was the pollutant from NOx that has the highest health impact. So I don't know, does that suggest that NOx is basically a proxy for other issues related to traffic, so other pollutants from traffic that we don't look at, maybe ultrafines or VOCs or...
Yeah, absolutely. That was when I was kind of kind of looking and thinking about this, is that was one of my things, because actually when you start to put it all into that table and go, what, this, and this, is this airways disease? NOx seems to be the thing that's consistent for everything. But actually, is that the cause of the issue, or is it just a marker of exposure? And I think that's a really very valid question, because it's the thing that struck me when I was kind of looking through these studies, is actually you start to think, actually, is it a marker and a surrogate? I actually measure nitric oxide in people's airways as a measure of asthma control. So we've got NO monitors, and we look for that as a measure of inflammation. So you start to think about this, and you think, actually, is this just a bystander that is a marker of other exposures that we're not picking up, and it's the thing that we measure, therefore we assume that that is causing the problem, or is it something else? And I think it's a very interesting question, and I think you almost need some toxicology experiments to be done to expose people to these individual things in controlled ways and see actually what is happening at the biological level.
And one of the questions might be, is it a proxy also for ultrafine particles? I mean, you mentioned PM2.5, but you didn't mention ultrafines. I mean, is there no study? Are there studies on ultrafine?
Yeah. So it's exactly. I think it's and I think that's one of the challenges. A lot of the studies that have been done is that they're using different methodologies and measuring different things, and to get that consistent message, I think, is actually there almost isn't a consistent message, because everyone's doing something slightly different, and I guess that's something to do with the team in Leeds have got access to this, and this, and they'll measure that because that's what they've access to. Whether you go to Manchester, they've got a slightly different machine, and they'll measure something else, and they'll find something else. And there almost needs to be a kind of a standardization in some ways, or a scorecard of this is, I don't know. Yeah, it's a really, I think there's methodological issues in the whole of this, isn't there?
Yeah, and that brings me to the first question from the chat then now. So Tim is asking, how do studies relate pollution levels to the individual's exposure?
I don't think they do.
Indoor pollution levels versus outdoor. I mean, I think,
I think they don't, and I think a lot of the studies, when they look at things, they use patient. They'll ask patients about recall, or they'll do it on a, you're measuring an exposure in a kind of a postcode, or that's when we did the bit with James, is we were looking at postcode. I think it was not even street level; it was kind of LS25 level. That was that. Well, within that postcode, it's such an enormous area. You can't necessarily do that, and so a lot of these studies are all use that kind of methodology where you look and go, well, we think this postcode or this area has been exposed to this. When you get down to the individual person, it's really hard. I don't think you can quantify it. And then within that, you've got the patient's behaviors. It's going to be someone who's working from home, as we all are now. It's going to be a very different role to, say a postman just kind of walking around the streets and getting exposed to loads of things. I mean, we saw in Leeds, there used to be an asbestos factory in Armley. And so one of the things we always ask about is asbestos exposure. That's what we're obsessed about. And you see people who've got signs of asbestos exposure in their lungs who've never worked with asbestos. And the question you always ask them, did you live in Armley? And they go, oh, yeah, I lived in Armley. And you go, well, that's fine. That's why you've got exposure to asbestos. And so you're seeing this kind of people who are walking through an area, or I think it's really hard unless you've got almost an individual monitor that records what you are actually exposed to. I think these kind of big epidemiological studies give you a hint, but I don't think they give you the detail necessarily.
Yeah, so the sensor technology is quite critical there, isn't it? In a way, it's a barrier. Next question. There's quite a lot of questions coming through now, so I don't know how long you've got, but is there any possibility that the reduction in admissions during lockdowns was related to the reluctance of people to visit hospitals?
Oh, absolutely. Massively. Yeah. So that was, absolutely very complicated as to what was going on there. But we certainly saw a reluctance of people to come into hospital. People were scared about coming in. And it's hugely complicated because also we took all our very vulnerable patients and scared the life out of them and said, you absolutely have to stay in. You can go out for an hour a day for a walk. Lots of real behavior changes. Even the fact that a lot of patients, some patients don't necessarily take their maintenance treatment for COPD and asthma regularly. They'll forget because of all sorts of things, but patients were really taking their treatment because they were scared and they were worried. So massive, yeah, I mean, I think there's a massive question to be answered there about what actually was the driver. But I mean, I remember driving in the kind of middle of the lockdown to work, and there was just no cars on the road. It took me 20 minutes to drive in, and it was a bit like a ghost. It was weird. It was a ghost town.
Through the pollution, actually, only NO2 reduced, PM 2.5 didn't.
Yeah.
Due to long range transport and other sources. So
yeah. So I think all sorts of things happen there, but it'll be.
Okay, next question from Kate. She's interested in the impact of indoor NO2 from gas cooking. Is that something that concerns clinicians? And would that be a way to tease out the role of NO2?
We don't ask, to be honest. I mean, we ask about, we'll ask about people who've lived in the kind of developing world. We quite often ask about open fire cooking, but we don't ask about whether you got a gas hob and things like that. We just don't ask that level of questions. Although interesting, I've swapped from a gas hob to an induction hob primarily because of gas costs, but also I just think actually there's a bit of a hint there that if you're burning natural gas in your house, it's possibly not the right thing to do. So I did it for 2 reasons. But yeah, we don't ask those questions. We ask about all sorts of other random questions about birds and things, but we don't ask about whether you cook on a gas hob. But I mean, it's, yeah.
Okay, Kate's got some anecdotal evidence. The cough got better when she swapped cookers. You can still burn food and produce huge amounts of gas.
Yeah, absolutely. Yeah, exactly.
Even on an induction hob. This is an interesting question. Are the WHO pollution limits, I guess the new ones, effective for protecting the lungs at the levels are set now for PM 2.5 and NO2?
I think the answer to that is probably any reduction is gonna help. I mean, I guess the only thing that would eliminate is if you got that down to 0, which you're never necessarily going to do. But I think it's absolutely going to help. And I think, as you increase up, the risk of these things increases. As you reduce down, you would anticipate that the risks would go the other way. So I think yes, that's a political trade-off, isn't it, about how much you can push it down and things.
Well, I don't think there's any air quality limits that actually match the WHO standards.
No.
That's a whole different.
Yes, yeah. And WHO certainly takes they do take a slightly different view on some global issues compared to the UK. Certainly during COVID, we were out of step with some things that WHO. So they do have a slightly different slant on things, not unreasonably because they're a global organisation.
And they're health focused, like you're saying. So we're actually at 1 o'clock now. So I don't know. Do you have to dash off, Ian? I mean, I guess we should probably wrap up just now because we're at time. If there's any other urgent questions that people have.
Oh, so I've got to be at clinic for 1:30, so I've got a little bit of time. So I'm not massively rushing off. Okay,
that's great. I suppose my last question would be then: what type of air quality data do you think would best support health-based studies? Is it exposure data, or is it higher resolution static data, or what is it you think you need?
I think we probably need. I think there's probably various strands. I think you almost need. I think the epidemiological and the kind of higher level stuff, I think is really useful because I think it gives you hints and it points towards things. I think shorter term, I think individual exposure, cumulative exposure, I think is going to be really helpful. I think actually, but that's really hard to do, to be honest, because you've got to have someone having a monitor on all the time, and how do you do that? But I think for short periods of time, I think that would be really helpful in terms of trying to tease that out. The real difficult thing is a lot of these diseases may well be that to develop COPD or to develop asthma is you need a long-term exposure, and the only way you're going to kind of see that signal is if you've got long-term monitoring of individual exposures, and that's going to be really hard to do. And I think, you know, you can put monitors in people's houses, or you could put them in their workplace, or you know, and you have to know they commute, or they suddenly change their job, and actually their risk change. I think it's just a really, it may be an area that we just can never crack because it's just so hard. And that's which is why it's nice about cigarettes, because you go, how many cigarettes, how many years, and you get a surrogate of exposure, whereas you can't really do that with a air. It's still almost invisible, isn't it? You can't see it in some ways. You got to quantify it.
No, so maybe the goal should just be to reduce emissions as far as possible.
Yeah, and just accept that this is what we should be doing, but I guess people like to, if you're making major changes to society, is they like to see that there is some evidence that it's going to have some benefit, isn't it? And it's yeah.
Okay, well, thanks very much. That's been fascinating, and perhaps we'll give you a chance to go get your lunch before your clinic. There's quite a lot of thanks coming through in the chat, but that's been very interesting for everyone. And thanks all for your participation.